start by talking about, again, a little bit of epidemiology and why we should be concerned about this. Cardiovascular disease is the major cause of death in our country and many other countries worldwide. It's interesting to note that more females die of cardiovascular disease than men, and this really underpins the Go Red for Women initiative of the American Heart Association, so that there's better recognition that this is a major problem in our society and often underappreciated and under-recognized. What are the risk factors? And we've talked about many of them already. We're going to talk about lipid risk factors now, but we shouldn't forget about hypertension, cigarette smoking, diabetes, etc., because as you'll see, all of these contribute. So again, some old data showing the relationship of serum cholesterol to coronary heart disease, and this is in Hawaii with Japanese males. And when you look at HDL cholesterol, it's the opposite. Those with higher HDL cholesterol are more protected. And so this creates the basis of what we're concerned about in adults. But the question has always been, is this something we should worry about in children or not? So let me talk about the rationale for why we probably should be thinking about this in pediatrics. And again, I mentioned the autopsy studies in my last talk, and these show that early coronary atherosclerosis does begin in childhood, and here are the risk factors. And you can see again, aorta, coronary arteries, fatty streaks, fibrous plaques, but you can see that the risk factors for the early part of the process are exactly the same risk factors that we worry about in adults. So this indicates that these are the things that we need to worry about, and we need to worry about early in life, not just in adulthood. And as I mentioned, risk factors tend to cluster in individuals and in families, and when you get that clustering of risk factors, you get dramatic increase in atherosclerosis. So again, the rationale really does support focusing on this early in life. Remember, these are individuals who died in their early 20s, late teens, so these are lesions that are already present very early in life. And what it leaves us with is a picture that looks like this. And so obviously we are born with healthy arteries, but over time we develop fatty streaks and then fibrous plaques, and that leads to these clinical outcomes that we're all very worried about. And the question is, couldn't we do something here to prevent that, rather than worrying about it in this age range? And I think there's increasing evidence that actually those who maintain low risk factor status throughout their lifetime, so for example, if you get to age 50 with low risk factor status, normal cholesterol, normal blood pressure, etc., your likelihood of having these events is exceedingly rare. And actually, it turns out your likelihood of having cancer and other adverse outcomes is also relatively rare. And so the person who gets to age 50 with low risk factor status may well live to age 90 and beyond, whereas the person who gets to 50 with multiple cardiovascular risk factors is less likely to have that kind of longevity. Now, we know that children and adolescents with elevated LDL cholesterol levels come from families that also tend to have both elevated LDL and a high incidence of coronary heart disease among the adult members. We also know that high cholesterol aggregates in these families, and that probably results from both shared genes and shared environment. We know that cholesterol tends to track over time, so that an individual with a high cholesterol early in life is likely to be an individual who will have a high cholesterol later on as an adult. And so this all leads to the approach to prevention, which really embodies two approaches. One is the population-based approach, sometimes referred to as the public health approach, and then the other is the one that occurs more in the physician's office, and that's the individualized approach. So how does this work? Well, the population approach really is aimed at lowering cholesterol across the entire population. And it's focused on creating a healthy diet that everyone in the population could and should be eating. And in children, we generally start at age 2 because we consider individuals younger than that really need a somewhat higher fat content to their diet. As there's this transition between age 12 and 24 months that we need to consider, and I think especially as we're more concerned about obesity, and again we'll talk more about that tomorrow, we probably need to begin the transition to a lower saturated fat diet around age 12 months, and that means that families can consider using lower fat milk, for example, in a 1-year-old as opposed to waiting to a 2 or 3-year-old. And by the time you're 2 to 3, you really should be in the more recommended diet pattern for all of our population. The diet includes a wide variety of foods. Energy balance is critical, so it should be energy that supports growth but is not an excess amount of energy that results in obesity. And the recommended nutrient intake includes saturated fats less than 10%, total fat 25 to 30%, limiting trans fats to as low as possible, hopefully 0, and lowering dietary cholesterol below 300 milligrams per day. Now, the individualized approach is the one that we tend to think of more in our offices. And this is the one where the pediatrician and the family physician needs to think about this on a regular basis. The idea is to pick out the higher risk individuals in our population, and this really calls for a team effort. So it's the physician, it's the nurse, it's the dietitian, et cetera, to identify these children and get them started on the appropriate kinds of therapy. So the first and fairly controversial issue is screening. When should we measure cholesterol in children and adolescents? And this is something that is discussed often, and I'll talk to you a little bit about what our current approach is and why I think we may need to modify that approach. So the recommendation since the early 1990s has been what's called a targeted screening approach, and that is that we should focus on individuals who already have a family history of either coronary heart disease or other cardiovascular outcomes, and that should include pediatric children and adolescents who may also have a risk factor. And the idea was that adult cardiologists would see these parents and grandparents. They would then make sure that the children got referred for lipid measurement, et cetera. And as you'll see, this really is a strategy that seems not to work very well. We would screen offspring of parents who have dyslipidemia, and there was sort of a loophole. Children and adolescents who had unobtainable family history, physicians might choose to measure. It turns out with family structure the way it is today, this is a more and more common scenario where the family history both of dyslipidemia and cardiovascular disease isn't as well known as we would like. And then finally, children and adolescents with other risk factors. So if they have obesity, hypertension, diabetes, et cetera, they should have a fasting lipid profile. Well, so what are the concerns about this? And there are a number of them that have emerged during the time since that initial recommendation. One, I mentioned, the family history may be difficult to obtain. One has to continuously update the family history in this screening strategy because if you think about it, young children have young parents and young grandparents. They may not have cardiovascular disease yet. These targeted screening guidelines were really based on the thought that we would get to a point where every U.S. adult would have their cholesterol measured and know what that number was and know what the interpretation of that number was. That would help for screening of children, and obviously we're nowhere close to that kind of a scenario. So parents really do not know often what their lipid values are. Now, this is a study that was done in West Virginia, and basically they compared a universal screening strategy where all kids would be measured versus a targeted screening program along the lines of what I just described. And they found that in the targeted screening program, 30 to 60% of children and adolescents with elevated cholesterol are missed for a whole long list of reasons that I mentioned. There's also some concern that fasting blood draws may be difficult in children and adolescents, and so we have a bit of a solution to that as well. So recently in the Journal of Clinical Lipidology, a group of us were asked to weigh in on this approach and focus on the fact that the primary goal of lipid screening is really to identify genetic dyslipidemia. And the cut points that we use are really designed to identify those children who, in particular, have heterozygous familial hypercholesterolemia. So the recommendation by this group was that we should screen all children and adolescents, and that we should use the age 9 to 10 age range. This is when the values of lipids and lipoproteins are most reflective of what they will be in adulthood. There are issues related to puberty which actually change lipid and lipoprotein values that make those during the teenage years, especially the early teenage years, harder to interpret. And then the primary goal, as I mentioned, was to identify these patients with genetic dyslipidemia, and if we also identified those with lifestyle obesity issues and had dyslipidemia on that basis, that could also be beneficial. And then finally, they could have either a fasting lipid profile or a non-fasting, non-HDL cholesterol. So here are the values that we use for total and LDL cholesterol. You can see acceptable, borderline, and high. And you can see that these numbers are in general lower than the numbers we use for adults. And that reflects the fact that cholesterol values are lower in children and adolescents than they are in adults. Now, it's interesting. This is a different approach than we use for hypertension, where we use percentiles, and where we have different percentiles based on different ages. And there's been concern that this may not work as well because we're not using percentiles, but there's now actually been some research suggesting that these more universal cut points actually work quite well and can work for children across the pediatric age span. Now, here are the numbers for the non-HDL cholesterol, and again, acceptable, borderline, and elevated. And I think this adds a very important new thing to our armamentarium, because now people in primary care can do screening without having to have a fasting child in front of them. And the non-HDL is calculated as the total minus the HDL cholesterol. Now this, I'm showing this slide not because of the algorithm here, but more to remind you that there are secondary causes of dyslipidemia as well. And as we identify children with these issues, we should be focused on do they have diabetes, do they have thyroid disease, do they have liver disease, kidney disease, etc. And while alcohol may seem like less of a problem in pediatrics, certainly in adolescents, binge drinking can be an issue, and it's something we need to be on the lookout for. So what about treatment? Well, again, you'll see that treatment is really a combination of lifestyle first, and then if that is not successful, then we need to think about more aggressive treatment. And dietary therapy really is the mainstay. So here's a slide that shows, it's an old slide, it's from the 80s. It shows the current, at that time, diet compared to what was recommended. And you can see that in general, and this has improved somewhat, but not to the level of recommended, that our diet is higher in saturated fat than we would like, higher in total fat than we would like, and that our polyunsaturated fats are lower than we would like. Cholesterol overall was in a range that was acceptable, although as you'll see, when we get to the higher risk kids, we'll want to lower that even more, and we'll want to get below 200 milligrams per day. So where are the major sources of saturated fats? Again, they come from animal products, and that is dairy, meat, and that sort of thing, although we shouldn't forget that some saturated fats come from vegetable products as well, especially palm and coconut oil, which we need to be on the lookout for. But it is clear that saturated fat, as it increases in the diet, it leads to an increase in cholesterol, and the reverse is true. As you lower saturated fat, you lower cholesterol. Major sources of dietary cholesterol, again, animal products, dairy, and meat. The good news is kids don't seem to like these organ meats very much, so that doesn't seem to be a big issue. But again, dietary cholesterol has an impact on serum cholesterol, and you can see the relationship here. So one way of looking at this is to create kind of a food diary, and so this would be looking at dairy products, and the idea is that you would list the lower fat products over here and the higher fat products over here, and then have patients or their parents circle which ones they use. And the nice thing about this approach is it gives you sort of an immediate, just a glance can tell you which side they're on. And as you can see, it also suggests that when they're over here, it makes it clear what kinds of foods they could switch to that could immediately reduce their total unsaturated fat intake. So the recommended eating pattern is to use vegetable oils and those containing unsaturated fats, and to choose prepared goods that are also made with unsaturated oils, etc. Now this is tough because our food industry, unfortunately, it tends to send us in the wrong direction. And so when we eat at fast food and other restaurants, it's not easy to choose items that are low in saturated fats, et cetera. You have to work pretty hard at it, and that's where good diet counseling comes in, and especially in this case where the help of a dietitian may come in. Again, eat more fruits, vegetables, whole grains. Really a DASH type of eating pattern works for lipids and lipoproteins as well as for hypertension. And as I mentioned, more low-fat dairy, and moderate the intake of red meat. Choose leaner red meats, poultry without the skin, and fish can be quite beneficial too. And egg yolks, being a major source of cholesterol, can be problematic and need to be reduced. Now, the important thing to mention about this diet is there's been concern. Is this a safe diet? Don't children need the hot dogs and other things to grow appropriately? The truth is that there's now sound evidence that suggests that this diet is associated with perfectly normal growth and development. It's associated with normal neurocognitive function, and so there is really no reason to be concerned about this diet. And as I'll show you in a second, we talked about the population diet, but as we get into the high-risk group, we tend to make some modifications. We want to lower the saturated fats even further, and we want to lower the cholesterol, as I mentioned, even further. And this is a harder diet to maintain, and again, I think you could argue that a dietitian is quite beneficial as an adjunct in terms of getting that accomplished. What about drug therapy? Well, again, this is another very controversial area, but I think the more we learn, and we now do have randomized controlled clinical trials, they're summarized in this paper by Brian McCrindle et al., that are really giving us more and more evidence that the statins are as safe and as effective in children as adults, and that effectiveness is primarily in lowering LDL cholesterol, but we now actually have some data that focus on intermediate outcomes, such as carotid intimal medial thickness, showing that statins actually can improve that situation as well. So the goal would be that children age 8 years of age and older, if they have not been successful in terms of diet modification, if their LDL value is above 190, that's with no other risk factors, or if they have other risk factors, if their LDL is above 160, then we need to consider drug therapy for those individuals, and the targets are over here. So what drugs do we have available? Well, essentially, again, they're the drugs that have been used in adults and now have trickled down to kids. I'll talk about two classes. One is the bile acid sequestrants. They act by binding bile in the intestinal lumen, and the nice thing about this is they're not systemic. Parents actually like the fact that their child is not taking a systemically operating medication. Here's the dosage. The tablet form has become more popular than the granular form. And as with most medications, the idea is to start low and advance. The problem is these drugs are not particularly palatable. So many children prefer the tablets, but they're quite large and you can't break them up when you provide them to the child. There are side effects, constipation, cramping, etc. It's recommended that patients drink a lot of fluids, that they also increase the fiber in their diet, and it should be remembered that these medications can bind with other medications as well, and so they shouldn't be taken together. There are a number of studies showing that these problems with palatability really, in many ways, trump their effectiveness. They are effective at reducing LDL cholesterol, and they're effective in the sense that they are additive to diet. So together you may get somewhere in the 10 to 20% lowering range if the medications are actually taken. Now, what about the statins? So again, we know a lot about them. We know how they work. We also know that they have some side effects that we need to be concerned about. The main one being the potential for rhabdomyolysis. And this is obviously something that can be followed with frequent monitoring of history of muscle aches and pains and that sort of thing. The good news is the side effects are reversible. The other thing that is important from an adolescent perspective is the question of teratogenicity. So they certainly have a theoretical risk of teratogenicity, and so for female adolescents who may be sexually active, they need to be counseled on contraceptions, and they need to know about this issue should they become pregnant. The cholesterol reduction is quite substantial. They can be used in combination with the bile acid sequestrants, and this may actually result in a lower dose of both of the medications, and obviously diet should be added here as well. The goal is kind of a sequential goal. I think our first target is to get the LDL cholesterol below 160. 130 would actually be the 95th percentile, and so we'd like to get it below that if possible, and even better if we could get it below 110, although this is difficult to achieve. And then the usual sort of follow-up where we see kids after starting medication in the 4 to 6 week range, we follow their fasting lipid profile, and we do safety labs, particularly directed at liver functions and sometimes at CPK, looking at muscle enzyme issues. Other tests as indicated, and then once the target's been achieved, those are patients that can be seen less frequently, and hopefully they will maintain their pharmacologic treatment as needed. The good news is that we do have ways of dealing with this effectively. I think we now recognize that this is an issue for our pediatric patients, and we need to focus on it both from a population and from an individual high-risk patient perspective.